So the final group of drugs we're going to discuss are the opioids. And this is kind of our segue into clinical medicine as well, because we can talk about the opioid um, crisis that's existing in this country right now. And so understand that from a historical sense, these drugs were isolated from the poppy. This flower grows in Central Asia, particularly Afghanistan, and some of these tribal areas that are very remote and very isolated. That's the bulk of their agriculture, is the production of these poppy fields. And you see these huge red fields in the springtime, right about now, covered in poppy. And of course, you don't actually harvest it from the flower itself. You wait for the flower to be pollinated, and the seed capsule closes on, and then it becomes like this round ball that leaks this white oozy material. That's the opium. And of course, it was named for the Greek god Morpheus. This is the only picture I could find where he had his clothes on. He's basically like a winged god that comes to people in their dreams and messes with their mind. So in terms of how these opioid receptors agonists work, we're specifically talking about the mu opioid receptor. Understand that there are other opioid receptors throughout the body, designated delta and kappa. But for today, we're going to focus really on the mu receptor and what these drugs do at that receptor level. So I have them kind of in order. So there's kind of a stepwise mechanism. So the drug binds to the mu opioid receptor and causes the calcium channel to close within that neuron. So then less calcium basically translates to less production of a neurotransmitter. And in this case, it's specifically substance P, which is one of the kind of smaller neurotransmitters. But there's also other effects. We can see cyclic AMP levels being reduced. That's going to profoundly affect the activity of the potassium channel. It's going to keep it open. All right, when the potassium channel is open, basically potassium leaves the neuron, causes the neuron to be hyperpolarized, and if it is, it's less likely to have another action potential. So this kind of introduces the neuroscience and the neurology of pain. Okay, and so Dr. Hefner, Dr. Hall, and some of the other people in anatomy or in physiology as well will probably spend a little bit more time on this than I will. But essentially, when we use opioids, we reduce nerve excitability, and then we alter the perception of pain. And so obviously the pain is still there. We just don't feel it, and it doesn't really bother us as much. And those mechanisms that I just described are basically found, postsynaptically as well as presynaptically, and that's all coming from these mu opioid receptor activities. And so the different types of opioids can be classified by their kinetics, but also on their duration of activity. And so I like this classification scheme because I kind of think it fits with this case, is that we're going to look at, acute pain, and this is really kind of an acute type of pain, this back pain. So there was some type of back trauma, and then a couple of days later there was back pain. Other pain that's associated with mild, or other procedures that are associated with mild to acute pain include something like minor surgery. Dental surgery would be a good example of kind of when to use these drugs. And so this is kind of in contrast to what I would classify as like strong or severe pain or chronic pain. So like a knee fracture, a really large joint replacement like a knee or a shoulder. Cancer is kind of a chronic painful condition. And kind of chronic, what I would deem like terminal conditions. And so, if somebody, and I know I have a friend who's a pain specialist, they would not like this classification scheme because it's very elementary, and I understand that. But it kind of puts it into kind of two buckets for right now. And so we'll talk at length about, when to kind of progress through mild to moderate versus, maybe moderate to severe pain, because there's obviously some gray zone between this, and everybody experiences pain differently, and everybody can tolerate pain differently, of course, too. So the drugs that I really want you to focus on for this back pain case are the ones that are most clinically useful for this type of patient. And so there's only three: codeine, hydrocodone, and oxycodone. Okay, and they're kind of ranked in the, um, I would say, in the potency of these drugs for pain. Okay, so codeine obviously is most beneficial for mild to moderate pain. Um, it offers weak analgesia. Typically, it's combined with NSAIDs and also with acetaminophen. Hydrocodone, a little bit stronger, and it's actually more effective when you combine it with NSAIDs as well. So the key benefit here to combining these morphine-like molecules with acetaminophen or with NSAIDs is that you basically have two different therapeutic mechanisms, okay, that basically govern a reduction in pain. And so you can actually get away with less of these morphine molecules by co-administering acetaminophen in particular with these. And so the formulation Vicodin, the brand name Vicodin, and the brand name Tylenol number 3 are both hydrocodone molecules combined with acetaminophen in particular. Okay, and it's been shown that when NSAIDs are combined with these morphine-derived molecules, that we don't have to use quite as much. And so one of the concepts is in terms of using NSAIDs or acetaminophen is that we won't have to use as much of these morphine molecules, and we can reduce our dependence upon these opioids. The problem is that some of these strong opioid agonists, specifically morphine and hydromorphone, fentanyl, and some of these other drugs, are really kind of being pushed on earlier in the pain management, and they're really identified for really strong pain, chronic pain that's breakthrough. Okay, and so we haven't really talked about breakthrough pain at the pain gate, but essentially it's pain that's experienced in between the doses of analgesics, whether they be acetaminophen, NSAIDs, or some of the other hydrocodone type molecules that we had talked about recently. Okay, and so these types of drugs are really kind of for more severe, long-term, chronic, debilitating, acute exacerbations of pain. All right, and so we'll talk at length about when to best use these drugs. And so these drugs would not be on your list of drugs that you'd need to know for the formative. I just want you to know where the where the heavy hitters are, so to speak, in terms of the opioid drug class. What I do want you to understand are the adverse and side effect profile to all opioids. So regardless of whether it's a mild or a strong opioid, they all produce sedation. So patients really shouldn't be driving on any of these drugs. They all have the ability to produce respiratory depression, and this is coming from a brainstem process through these different opioid receptors. They all can produce nausea and vomiting because they hit the chemoreceptor trigger zone, or the CTZ. They all produce constipation, and so now we actually have another group of drugs, another drug class that specifically helps treat opioid-induced constipation, because all these patients who are addicted are also constipated. Okay, you can also see histamine being released, and that can cause hypotension. It can also cause flushing of the skin, as well as itching. And so when high doses of opioids, you can see meiosis, you can see changes in the pupil size. And of course, all patients experience euphoria when they're on opioids. And as part of the problem that contributes to their dependence liability is the fact that there's an increased release of dopamine within the reward pathway within the brain. Patients feel great when they're on opioids, and they have no pain. And the fact that they're cheap really kind of contributes to this opioid epidemic. Okay, and so those are the main side effects. I think it's important to know all of them because these are ones that are problematic, and these are the ones that can be specifically in the case of respiratory depression, can be quite deadly. All right, so that was our introduction to opioids, and if you have any questions, let me know. Thank you.